So the lab itself goes through kind of what we're going to talk about in class tomorrow as well, what you're going to check before you actually extubate the patient. There has to be an order for an extubation. You can't just go around pulling endotracheal tubes out, and they don't like that. Okay. So before an order is written, you have to communicate to the physician what it is, where the patient's at, what kind of values you're getting for, let's say, RBSI. Have you done a cuff leak test? How long have they been on pressure support? What their gases are like. So there's a whole bunch of things that you're going through before you try to determine whether you need an order to extubate. It's going to be part of your plan anyway. When you start doing soaping and everything else, that will be your plan probably for the first couple of days as the patient's getting better. So really what you want to look for is, has the reason the patient was intubated, is that gone now? Okay, so remember the 4 Ps, so those have to be non-existent in order for you to extubate that patient. Okay, so that's what you kind of have to consider. Okay, also look at cardiovascular status. What's their blood pressure like, heart rate? What kind of medication are they on? So their sedation levels should be fairly light at this point. Not always. Sometimes we do what we call a one-way extubation. The patient is going to pass anyway. And maybe we're doing this just more for comfort of a patient and also family. And then that if that's the case, then we wouldn't worry so worried about all of the predetermining factors for extubation at that point. It's more of, this is going to happen, and the patient is probably not going to survive. Okay. So we wouldn't put them through all the different tests. But if this was a fella, let's say he was on the ventilator for a period of time, it hasn't been 5 to 7 days, which is what we usually wait before we do a tracheostomy. He's doing great. Gases are excellent. He's on pressure support right now. Volumes are great. Cuff leak, yes, there is a difference between inspiration and expiration on cuff leak. So I'm not too concerned about there being any swelling, but be prepared anyway. Okay, so we've still got his suction attached. So we've got closed suction, and this is the attachment to the ventilator at this stage. Okay. All right, so I prepare everything that I'm going to need. What am I going to need for extubation? Kind of things what I need.
Suction and then have oxygen on standby.
Yeah, you betcha. So I'm going to need suction. So I've got suction catheter, but I'm going to have my yonker ready to go. Yep. What else? Resuscitator. Resuscitator. Yep. I'm going to have my resuscitator bag with flex tube on it, but I'm also going to have a mask. Okay, so I've got my bagger attached to kind of oxygen.
Have a drop cloth or something for the chest?
Yes. So I've got my mask for my patient. I'm going to put something on their chest. Oops. 5 seconds. Okay, can be at about a 30-degree angle or sitting up higher if they can tolerate it. Okay, so get really good diaphragmatic movement. All right. Looks just so uncomfortable. Whee! Oh. I'm gonna fall down. Okay. Sit, stay. Good boy. Okay. All right. So we've got suction. Suction's on. And we're going to set up oxygen for post-extubation. Okay? So right now he's on 35% on the ventilator. Okay? And I'm going to set up a nebulizer. It's got water in it. What do I set the FiO2 at? 45%, right on. So 10% above what they're already on. Okay? Got my mask ready. Don't need the tongue depressors anymore. Okay, got some gloves on. Get my eye protection on because he's going to be coughing. And I would do what? Yes. Now what I'm going to do?
Talk to him?
Talk to him?
Yeah.
Sure. You bet, absolutely. Tell the patient what you're gonna do. Okay? Okay, Mr. Smith, we're gonna take that tube out. He's gonna go, yay! Thank you so much. Well, he won't say that yet, but he will when we're done. Okay? So we're gonna tell him it's gonna be a little bit uncomfortable when we take this tube out. Your throat's gonna feel a little bit raw or a little bit sore. Don't worry, that will go away. And I'm gonna get you to really cough when we get that tube out. Okay? So explain what you're gonna do. Now it's gonna get my equipment ready. I'll be back in a second. So got everything ready, and then I'd listen to their chest. Okay? I'm gonna auscultate and see, do we need to suction? Or can I get him just to cough? Okay? Before we get going. Okay? I'm gonna say his chest sounds pretty clear right now. All right? If he has a VAP tube in, which this one does not, if he has a VAP tube, I'm not as concerned about secretions, and it's functional. I'm not as concerned about secretions sitting above the cuff, okay? But if he does have a VAP, I would disconnect it from the suction and clamp off the VAP connector, okay? Because he does not have a VAP tube in, I'm going to suction orally first. So it's just as clear, but we're just going to suction his mouth out before we get going. Now, you can't get this really far back. I mean, it's not going to get above the cuff, okay? So you can get it back there and make him gag like crazy, okay? And get as much out of it as you can. There's still going to be some secretion sitting above the cuff. If you really, really, really wanted to torment the poor person, then get a suction catheter and try stuffing it down there, okay? But that's just mean, especially when the sedation's lightened up. Okay? They're going to be coughing, so I'm not too worried. Okay? All right. So I've got my yonker on. I am going to get a syringe. Oh, the box without a syringe. Oh, and okay. Syringe, I'm going to attach it to his cuff. I'm going to disconnect all of my bow tie that's going on here. Oh my lord, look at all the knots. Okay. At this point, I really don't care whether I'm holding the tube or not. Okay. So with extubation, we have him take 3 breaths in. 3 big breaths, okay? And on the 3rd breath, on peak inspiration, I'm going to deflate it before then. Deflate the cuff and pull the tube, okay? So you kind of have to time it with his inspirations. Why are we pulling it at peak inspiration? Glottis is open. Yep. Why else?
So that they have air in to cough.
Yes, absolutely. Okay, their lungs are full, so when you pull that out, they are going to cough as soon as you start pulling it out. They're all ready, and they will cough out whatever is above the cuff. Okay, it'll start trickling down as well. Okay, so that will help prevent any aspirations that may occur. All right, so we've got ties undone. Okay, I'm going to explain the procedure to our patient. Mr. Smith, I'm going to get you to take 3 big breaths. On that 3rd breath, I'm going to pull the tube out. After that, you're going to be coughing quite a bit. And he nods his head knowingly. Okay, so big breath, 1. Another big breath, 2. Okay, big breath, oops, and I take off my deflate the cuff, peak inspiration. We're going to pull it out. Obviously that was not lube. Okay, he's going to cough, cough, cough. This can just get kind of wrapped up in their little thing that you've got hanging off here. Okay, suction. We don't have to go to the way at the back of the throat. I'm just going to put it there just like at the dentist. He's going to cough up into it, and then we can put the mask on. That would be on at about 15 liters per minute. Okay, so he's on 45% oxygen, extubated at peak inspiration on the third breath. Okay, I'm gonna sit and watch him. Okay, Mr. Smith, can you talk to me? I want him to talk. Why? Why do I want to hear him talk?
Like a muffled voice or something like that.
You bet. I'm looking for muffling of his voice. He will sound a little croaky, that's okay, but the muffling part will tell me we've got an upper airway obstruction. Does he have stridor? Okay, so these are the kind of things you're kind of keeping an eye out for. If you're seeing signs of stridor, then this would be the opportunity to give him the nebulized epinephrine that you have, and also some Decadron or dexamethasone IV. Okay. We may also have to increase his FiO2 depending on what's happening with the saturations. Okay, so we're trying to maintain adequate saturations. So this is why it's really important to look at where their saturations have been before you extubate, and make sure that you bring their sats back up to where they should be post-extubation as well. Okay, so really watch everything. You're watching the cardiovascular status, you're watching the work of breathing. Okay, so we don't go very far once we've extubated a patient. And really, the nurse is there as well, because you're most likely doing this in an intensive care unit. The nurse that's looking after this patient will be with you the whole time as well. Okay, so that if something should happen, like a huge amount of stridor, then we're gonna call everybody in. The intubation cart's outside the room, in case we have to re-intubate the patient. Okay. If they're asthmatic, we're looking for bronchospasm, we may have to give them some salbutamol. Okay, but primarily we're looking for, is that swelling becoming so significant that we may need to re-intubate again? Yeah, so we're watching, and then after about 20 to 30 minutes, we do a blood gas. Okay, or a draw sample. They most likely will have an art line in. Okay, so we'll do gases and see where we're at. Over there.
Is that all a one-person job, Heather?
Yeah, usually, yeah. When we did extubations in the ICU, it'd just be the one RT, or student. We'd drag a student in and have them do it. It's always fun to do it that way. But the nurse is always there. Okay. And if there's any medications that need to be given, she'll be giving them, except for the nebulized ones, and we would give those. Okay. So we'll leave them sitting up, because it's much easier to breathe sitting up, and then clean up whatever we have to clean up, and then keep monitoring about every 15 minutes.
Would the physician order for the extubation have nebulized epi if needed in it then, or would you have to get
No, we kind of use that as our own, do we need to give it or not? We have the right to give whatever medication, we'll just get an order for it afterwards.
Okay.
Yeah.